All right, everyone. Thank you for attending our last GAAPP Academy from this year. I'm very glad that today we have our last very special session with Mr. Neil Bertensen, sorry. He's an expert consultant and patient involvement in HTAs, and today he will give us this master class on patient involvement in health technologies assessments. If I can get my slides to work. Okay, my PowerPoint is not happy today, but I just wanted to let you all know that today we have Spanish translation available. So if you want to listen this webinar in Spanish, please go to the interpretation menu on the bottom right of your screen if you're using your computer, or in the three dots if you're using your mobile phone, and you would choose Spanish. Si querés escuchar este webinar en español, por favor, selecciona la opción en el panel de interpretación que encontraréis abajo a la derecha. So before we start, as usual, we would like to say thank you to our GAAPP Academy sponsor that has supported GAAPP and its partners during these 6 GAAPP Academy sessions that we have during 2023. So thank you very much, AstraZeneca and GSK. And in this occasion, we also want to say thank you to Novartis, who was the sponsor for the original content that was created for the chronic urticaria capacity building module, that you will see adapted today for all respiratory atopic and allergic diseases. So with further ado, I will give the podium to Neil to give us this master class in HTAs. Neil, it's all yours.
Thank you so much, Victor. And it's great to be here. And thank you to all the attendees for coming as well. And so let me start sharing my screen. Just hold on 1 second while I do this and put it on presentation view. So what we're going to take you through today, we are going to cover mainly HTA, but I want to put HTA into context. So we'll talk about policymaking, we'll talk about regulatory, and then we'll focus on health technology assessment, and I'll explain a bit more as I go along there. And I'll try to go reasonably quick through some of this, and then make sure that we have time towards the end so that you can ask any questions that you want, or we can have a discussion. So let's start. So first of all, why am I here talking to you about these things? Well, I've been working with health technology assessment bodies and regulators for many, many years, as well as with patient groups and the industry, obviously, and the academic research community. So I'm part of an international scientific society called HTAI. And there specifically, I work directly with health technology assessment bodies to help them think through how they can better involve patients and take patient evidence into their work. I also work on big sort of multi-stakeholder initiatives such as Paradigm. And there I focus very much on how to involve patients in regulatory and HTA early dialogues. So that's the discussions that happen before clinical trials start. And it allows the regulators, the patients, the health technology assessment bodies to hear what a medicine developer is planning and to give feedback to that. And obviously working with patient groups in industry on how we can all work better together. But I am a patient advocate as well, not in the same areas that you're in, but I actually started in the 1990s in HIV. And so I've seen this from the patient advocacy point of view as well. And I'll try to bring that alive when we're talking through all of this. So let's get started on the content. So I'll talk about policy decision-making, regulatory, then we'll focus much more on access and reimbursement, how those decisions are made, particularly in terms of when you have a health technology assessment body that is making those recommendations or those decisions. And then we'll just pull that all together towards the end and then have a discussion. So policymaking, I like to start with policymaking before we get to HTA, because this is really what is behind health technology assessment. It's the policymakers that decide exactly how medicines are reimbursed, especially within public healthcare systems. So everything about our healthcare is shaped not by us, but by the decisions of other people. Everybody wants to do the right thing. The industry wants to develop the right medicines. The regulators wants to make sure that they've looked at the science and they approve the right medicines for use. Your government, wherever you are today, will decide how much budget they allocate to healthcare compared to education or defense and those kinds of things. And then the payers or your insurers or your health technology assessment body, depending on where you live, they decide what should be paid for within the healthcare system or within the insurance system. Even right down to your local hospital in the city or town where you live, they make decisions to decide what resources do we put into different departments within our hospital. So how do we think about how we allocate resources between, for example, oncology and some of the allergy specialists that we have there? Even your family doctor is making decisions all the time when they see you about what guidelines do I follow? How much time do I spend with this particular patient that's in front of me? So we're all making decisions. And even us as patient advocates and patient groups, we make decisions too. We decide what services and support we should be providing to help our members and our communities. So all of these decisions happen, but the problem is not everybody has the same idea about what is best. We don't always agree. We all want to meet the needs of patients, but a hospital might say, let's make our process more efficient. A politician might say, I want to do things that are popular because I'm up for election soon. The regulator might say, I really want to just concentrate on the clinical evidence and really focus on that clinical evidence, and maybe I'm going to spend less attention to other kinds of evidence. The payer, the insurers, and the HTAs may say, we need to manage the budget. We need to think about the cost here. Your family doctor wants to manage the patients effectively, but also as quickly as possible so they can see more patients in a day. And the government, they're worried about the growth in healthcare costs. So how do they limit that? That's a question that they have. So you can see that all of these kinds of processes, these kinds of thoughts are sort of in conflict with each other. And that's why we have to recognize that each of these points of view is valid. It's okay that a hospital wants to be more efficient. That's where they're coming from. It's great that the doctors want more productive consultations and satisfied patients. Society wants people to be able to support themselves and others, such as their children or their parents. But we as patients, we want to feel better. We don't want to feel a burden on others. We want better mental health, and we don't want the condition we have or the treatments for it to get in the way. So we all have different values, and that's absolutely fine. And that's why we have health policies. So health policies aim to address these differences by setting standards, targets, priorities, budgets, and rules. So what's our role as patient advocates? Yep, we can certainly campaign. So we can protest on the streets, we can draw attention to the needs of patients that are not being met by our healthcare systems or our societies. And that can get a lot of attention, but it's not how a lot of change happens. Often what happens is what we see on this slide is when we as advocates work in partnership with decision makers and collaborate with them on solutions. And in my experience, that's where we see lasting change happen, because people start to understand different points of view and start to think, okay, this is difficult, but if we work together, maybe we can find a solution. And it's this kind of collaboration that I want to just touch on. in this section. First of all, I won't spend long on this, but it's worth just bearing in mind that there are so many levels of policy and decision making. At the global level, you have organizations like the World Health Organization who can set global health priorities. At different continents, you can have organizations that work at the regional level, such as the European Union or the regional chapters of the WHO. And they'll tend to focus on making sure that they're removing some of the differences between healthcare within their region to try and make it more equal. At your country level, you obviously have ministries of health and ministries of finance, and they're really setting the national priorities, the budgets, and the plans for particular diseases. But at the national level, you also have your medical associations who are setting guidelines of how to treat these diseases and different protocols of how those guidelines should be followed. As you go down to your local region, so your state level or your local district region, that's where you often get a lot of healthcare decisions made around many aspects of healthcare. They might be saying how many hospitals they need in the area, how the ambulance service is resourced. And they usually have much more control over social care. So that's not the medical care, but the social care that's looking after people with different conditions. And that's often financed and resourced at the sort of district level. At the city, these are the policies of your individual hospitals and clinics. They set their priorities, their patient pathways, their processes, and their staffing levels. So they're the ones that determine really how long you have to wait to see a specialist, because that depends on how many specialists they're paying for within that hospital. And I would say that it's actually often at the city and then at the local level that we can have quite quick changes in policy, because it's much easier to work with a hospital on their processes than it is to work with a national government on their processes. So change happens more quickly there, and certainly even more quickly at the very local level. The doctor you see, whenever you go for your doctor's appointment, that's a doctor you already have a relationship with. That's a doctor that you can already have a think about. How can we make the process that goes from the local doctor to the hospital to getting care easier? How can we impact diagnosis, have better referral to specialists? That's a conversation you can already have with the doctor that you see all the time. So my top tips for looking at this is, depending on your organization and where you're focused, really start thinking through which level of policy making do I want to be aiming for. And if you're a small organization, I would say that really thinking about that city and that local area, start with the institutions or the clinics that you already know well. Talk to the people you're already in contact with. You really start asking those questions. What can be improved? Really listen. So don't just make demands, but listen to them to understand the decisions they're making and understand what they're in control of and what actually their bosses and their bosses' bosses are in control of. So you understand what they can change and what they perhaps need to work through up the chain in order to make changes. But be really clear with them on the challenges you're hearing from your patient members. That kind of information, patients are not very good at telling doctors what is going wrong, the way that the system works. And so you, as patient advocates, are often that really clear voice that helps bring those issues directly to those that can make decisions. Okay, other top tips. Obviously, policymakers, they're driven by the news cycle and news stories. So I'd say news stories, local elections, local events, they're really good opportunities to engage with policymakers. So if there's a news story, for example, in your local paper or your national paper that starts talking about challenges with healthcare, you can follow up with anybody who's quoted in that article. Just find them online and say, I read your quotes and I agree with you that we need to fix this. How can we help do this together? And I think when you have national and local elections, that's a real opportunity where people, politicians especially, are willing to listen much, much more and willing to put forward some of their own ideas. And you can give them new ideas too. You can give them challenges that they need to fix should they be elected. And even if you have at your local hospital or clinic, maybe there's a new wing of the hospital being opened or a new department. They often invite people from the patient community and they invite politicians to attend these kinds of events. That's an ideal setting where you can make new contacts. So when you're in those social situations, like, you've got your glass of wine and you're mingling within this opening, be really careful about how you start those conversations. You don't see a politician and say, we demand all of these things. What you really need to be saying to them in that social situation is, we have a lot of insights that we gain from our patients all the time. And I think you really need to hear them. It'd be great if we can work together on this. Can we have a meeting together? Because working together, we can achieve so much. So be very positive and collaborative when you're meeting these politicians for the first time, and really position yourself as an enabler, somebody that can help them solve some of the challenges that they have. Okay, so in essence, I think when we think about working with policymakers, we often think like this picture here, where it's sort of like this big important meeting and there's a lot of important meeting around people around the table, and it's all very serious. And my tip to you is really, this is how policy making happens. It happens in a much more informal way a lot of the time. It happens over coffee, it's conversations, it's being really honest and open about what each side has in terms of challenges, what they find easier to solve, what they find more difficult to solve and why. And exploring that in a very open way can reveal new ways of tackling some of the issues you and your patient communities are facing. So that's policymaking. I'll just briefly talk about regulatory, and then we'll concentrate on HTA. So regulatory decisions. So the first thing is I'd like to talk about the difference between the regulatory assessment and the health technology assessment or payer assessment, because they're fundamentally asking different questions. So what the regulator wants to do is they want to basically say, does the evidence show that the benefits of a new medicine outweigh any potential harms? So on balance, do we think that's true? And that's how they make the regulatory decision. And what they look for in the evidence is they try to isolate the effect of the new medicine and say, can I just be really sure what this medicine is doing, what it's doing in a positive way, and what are any potential negatives of this medicine? And then we can have a discussion on how we feel about those two things together. What HTA and payers are doing is they don't want to isolate the medicine at all. They really always want to compare the medicine. They focus on the difference between the new medicine and what's currently available within their healthcare system. And what they're asking is a different question. Is they're saying, does the evidence show that this new medicine brings additional benefits compared to current treatments or ways of dealing with this disease? And are those benefits big enough and important enough to justify the investment? And the reason why I'm showing you this slide is because it means that the way evidence is interpreted by HTAs is different from the way it's interpreted by regulators. So a lot of patient organizations say to me, but if it's been approved by the regulator, why has my health technology assessment body decided we shouldn't pay for it? And actually it's because they're looking at different parts of the evidence and they have a different focus on the evidence. And I'll explain more in a while. The great news is in many countries, both regulators and payers are increasingly seeking the input from the patient community. And they're doing this because they want to improve the quality of their decision-making and understand the needs, experiences, and preferences of patients. So they've learned that without that knowledge, they can't do such a good job. An example, I won't go into detail for this one, but an example is, this is from the European Medicines Agency. And I just showed this to say that every committee where they're making decisions now has the involvement of patients. And any communication that goes to the public also has the involvement of patients to make sure that information is understandable as much as possible within the rules. And so we've seen this build over the last 10, 15 years. So now most regulators, not all, but most, understand that patient involvement is a critical part of the work that they do. Similarly, if we look in the USA, so the FDA in the United States, they're also very much focused on understanding the patient perspective. And this is the key areas they say that they're interested in. Signs and symptoms of a condition. What does that burden of living with a disease look like? How does it feel to have this disease, and what effect does it have on people's lives? They sometimes want to know about what's the burden of participating in a clinical study. They want to know about the treatments, especially the current treatments, not even just the new ones. They want to know what's the impact of treatments on daily activities. They want to know what's the most bothersome signs and symptoms that patients have. What's the burden of managing the disease? So not just the symptoms, but that daily burden of managing your disease. They want to know, what does that feel like? How does that affect your life? And the impact of the disease overall on daily activities. So that shows you the kinds of questions or the kinds of areas that regulators are focused on. Now, how it works with regulators, say you have a new medicine that is being reviewed by a regulatory agency. Well, they will usually invite some patients or patient advocacy groups to come and give testimony. And so it is an invitation. It's not that everybody can just turn up. And so one of the things it's important to do is to let your regulator know that you exist. So outside of any current assessment of a medicine, I'd always recommend sending an email to your regulator. It could be your national regulator, or if you're in Europe, you could send it to the European Medicines Agency, and just explain your organization, its remit, its geographical reach. Really emphasize that you're connected to patients with the disease. That's what they're really looking for. So you're able to bring insights from people, many people who have this condition. That you're willing to be part of any future discussions, and that you have the ability to come with evidence from the patient community. So that puts you on their radar. It means that later, years later, whenever it is, they might be looking at a new medicine in your disease area. They can say, who can we contact for that? And then you're on their list already. So that's a quick tip from me. Another one is, if you are invited to give testimony at a regulatory meeting, you usually have a very short time. It can be a matter of minutes to present your point of view. So the first thing that I would recommend is focus on the patient perspective, not the clinical evidence. The reason why I say this is there are other experts that can discuss the clinical evidence. Even if you're great at clinical evidence, what you've been invited there for is to bring the patient perspective to life. So really, really focus on that patient perspective. So focus on the burden of the disease and how it's not being addressed currently with standards of care, the impact of the disease on daily life, symptoms that are most bothersome, any challenges with the current disease treatment and management, and key areas that are still not being met by the current available medicines. Another tip is where you can put evidence behind that. So maybe from your surveys or interviews you've conducted with patients. And then seriously, I know this sounds stupid, but seriously, practice in front of a mirror. If you practice in front of a mirror, sometimes you have to get this down to 5 minutes. So make sure that you can get all your main points across in a very short period of time. I can see there's some things in chat. I just want to check if I'm missing anything in the chat. No, it's great. Okay, thank you. So case study. So this is European Medicine Agency. What they do is they invite patients as part of a process called early dialogues. And that's the scientific advice that the European Medicines Agency gives a company before they launch their clinical trials. So a company will come to the European Medicines Agency and they will say, we're thinking of running our clinical trials like this and collecting this kind of evidence with these kinds of clinical studies. And they want advice from the regulator to say, okay, do you agree with what we're planning to do? And what we've been campaigning for, and happens most of the time now, is to make sure patients are part of that discussion. And this was a study done by the European Medicines Agency to say, how's that going, having patients in the room? And so this slide here shows that the patients were able to give feedback on who's included in a clinical trial, who's excluded. Are these the right endpoints we're measuring? Are we looking at quality of life properly within this clinical trial? Is it feasible for patients to be involved in this clinical study? Anything that's going to stop patients from being involved in this study? Are we comparing this to the right standard of care within the clinical trial? And is this the right comparator, the right other medicine that maybe the new medicine is planning to be tested against? So that's showing us that across all elements of a clinical study, the patients are able to give some really solid feedback. I like this slide, but probably not for the reasons you would expect. So this is where they also looked at, what was the impact of having patients involved in these meetings? And people focus on this left circle with 71%, because that's great. 71% of the time, they could see that the patients were bringing real life experience, and they do look for that. I actually want you to focus on the last circle on this slide, the 14%, raising issues that had not previously been considered. Just think about that for a moment. Here you have a committee that has a lot of different stakeholders. You have clinicians there, you have the company there, you have the regulators there, you have other experts there. And actually, more than 1 in 10 times, the patients are raising issues that nobody else has thought of. And that's really important. For that 14%, for me, that's not a small figure. That is fantastic. That actually, when something is missing that is patient meaningful, patients are in the room to raise their hand and say, yeah, but you've forgotten about this. That's really important for us. And that shows you this statement that the EMA put out as part of this report they did. They say the day-to-day experience of living with the condition and its treatment can only be addressed by someone with first-hand experience. Really clear here that they want that first-hand experience of a disease in the room. Patients fill an important gap by providing real-life experience of the condition and their treatments, in addition to providing input into the clinical aspects of the development plans. So that's the development plans, the evidence plans, the clinical study plans of a medicine developer. So that's, in a nutshell, sort of regulatory. But what I really, really wanted to focus on today is the HTA and the reimbursement side of things. So let's go through this. So I want to start at the basics. Some of you will know HTA, you will understand it, but I want to make sure that we always start with a common understanding. Okay, HTA, Health technology assessment. And a health technology is a medicine or it's a medical device. It's some technology that is designed to change a person's health state. Usually we think of this as medicines, but it's not just medicines. It can be diagnostic tests and things like that as well. So that's the reason why it's not called medicine assessment, but health technology assessment, because it's more than medicines that gets looked at by this process. It's different in every country. So no two countries have exactly the same system. But essentially, they all try and do similar things. They want to consider the evidence about a new technology, and they want to compare that with what is used currently within their national healthcare system. And they do this because they want to decide if this health technology should be used, and if so, how best to use it, and in which patients. So which patients will benefit from it the most. And why do we have this? Well, we know the answer to this question ourselves. It's because we don't have a bottomless pit of money to pay for everything. So we have to make choices. It's become impossible to pay for everything within public healthcare systems. So we need to make choices, but how can we decide who gets what? Well, we could give those who shout the loudest or have the best connections what they want. So those patient organizations that always get into the media, that are able somehow to get the attention of the politicians, they could get what they need because then they're happy, but that leaves nothing left for anybody else. So that's why we have HTA. It's by reviewing the evidence and making a judgment based on this evidence that we make these choices. And so HTA was really trying to solve this problem about how we can decide whether a medicine should be paid for within a healthcare system based on the evidence rather than on opinion or on the share of voice a particular patient community might have. But it's related to policymaking, which is why I talked about policymaking at the beginning. This is the official definition for HTA. And it says, this is a multidisciplinary process. So that's telling you already that it's not one point of view they're considering, but they're considering multiple points of view when they make these decisions. And it's determining the value of a health technology, but its purpose is to inform decision-making. And I just really want to focus on that for a second, because there's a myth here. Most people think that HTA bodies decide which medicines are available. And that's true in a very few countries, but in most countries, that's not true. So people think that HTA is the body that determines the access to medicine, and it's based purely on evidence. In actual fact, it's the politicians who decide. So in most HTA systems, the HTA body will make a recommendation, and the recommendation goes to another separate committee, usually part of the Ministry of Health, sometimes Ministry of Finance, that will look at that recommendation and decide whether they are going to follow that recommendation or make a different decision. And this is another way of saying the same thing, that HTA provides evidence-based input to policymaking and seeks to promote evidence-informed policymaking. So HTA offers a bridge between the research, the evidence, and the policy. And it's the policymakers, your politicians, who decide how much resources are available to healthcare, the priorities of healthcare spending. Are they going to give more money to one disease over another, for example? But they also decide how big your health technology assessment body is. How many staff does it have? What budget does it have? And that very much determines the kinds of patient involvement that your HTA body might be able to afford to do. Policymakers also decide the focus of the assessment process. So an illustrative example, this is in cancer, so not in your disease area, but I think it shows this distinction. So in the UK, in England, in the early 2010s, most new cancer medicines that were reviewed by the HTA body in the UK did not show enough value to recommend reimbursement in England's National Health Service. And so that creates a challenge. What do we do in that case? So we could decide, the government could decide, there's something going wrong here. Let's change the way HTA works so that we don't have this problem. But they chose to do something different. They created a separate cancer drug fund that would be used to fund these cancer therapies that had not been recommended for reimbursement. So instead of fixing or changing the HTA process, they just said, no, we'll just create a whole separate process with a whole separate pot of money to pay for that. And that's what they did. So that shows you that the politicians can sometimes overrule health technology assessment and find other ways of paying for medicines that are not accepted or not recommended within health technology assessment processes. So I think a key opportunity for patient organizations is to think about how do we want to change or adapt the system. So there you really need to understand your national landscape, the system you have and how it can be improved. You then need to identify partners, not just across the patient community, but also think about the physician communities, the medical societies in your country that you can collaborate together on and make some requests for change. Together, then, you're a much stronger voice, which allows you to reach out to key policymakers and see, okay, how can we make this change? Is it possible? How can we start the discussions? And it takes a long time. You have to continue the dialogue. It doesn't happen straight away. So you have to have some patience here as well. Let's get into a bit more detail here about health technology assessment itself. So the world we had in the 2000s was that HTA bodies said, do you know what? We can do this without patient input. We can get the evidence from the industry. So they'll provide us with their evidence, their clinical trials, and we can look at that. We know clinicians in this disease area, so we can invite some clinicians and they can tell us what they think about this. And we also know economists. So if we're thinking about this in terms of the cost to healthcare, we can ask the economists, and considering all of these points of view, we can make a recommendation of whether this treatment should be reimbursed or not. The problem is it all breaks down, and it breaks down because when a new treatment becomes available, the evidence never tells the full story. So the clinical studies provide only part of the story. They show us what happens in a very controlled situation with a controlled, narrow, defined patient population. So a key question that comes up is how will, if you like, real patients or everyday patients, a much wider group of patients, how will they see the benefit in the real world? Also, clinical trials only last for a short period of time. So there's a critical question here. Okay, this treatment seems to work for 24 months or 36 months, but can we be sure its benefits will be long lasting? There are also key questions about quality of life and the way quality of life is measured in clinical trials. So these standard quality of life measures often miss very important patient impacts related to the disease itself. So they're missing sometimes, so we lose part of the picture. And I think with patient-reported outcomes, when people have to fill in these questionnaires as part of a clinical trial, a lot of people don't fill them in. So there's often a lot of missing data there, which means interpreting these sort of measures within a clinical study is not easy. And I think the big problem that we see in HTA when they're looking at the evidence is often they're saying, okay, in your clinical trial, you measured against placebo, or you measured against a treatment that we no longer use anymore. We don't have any evidence of how this new treatment compares to more recent treatments that we have available within our healthcare system. So you have this lack of evidence about the relative performance of this new treatment against more recent treatments that have come around over the last few years or 5 years. They're usually missing, and that creates a big problem. In HTA world, we call these uncertainties. So this means as a HTA body, we can see what happened in a clinical trial, but we're uncertain how real that will be seen once we move into the general clinic. Will we really see the same outcomes in patients in the real world as we saw in a clinical trial? That's one of the main challenges that we have here. So the traditional approach breaks down. We don't know really what is meaningful to patients, which outcomes are most important. Just grab a drink for a second. Are there particular needs for subpopulations of patients? So are there particular kinds of patients that we need to be focusing on because they're really high unmet needs? Often we have disease scores within clinical trials that are used. So sort of different measures, and they'll say, oh, it's a 2-point improvement on this clinical measure. What does a change in these disease scores really mean to patients? Excuse me. How does any change in clinical practice impact patients? Dr. Excuse me, I'll just go on mute for a second. I'm just recovering from a cold, so do excuse me. So they want to know who will benefit most from this technology and what is the real value of this treatment. And to answer these questions, that is exactly why we need to be in the room. Because we, as patient advocates and patients, can clearly explain the impact of often poorly understood conditions to the HTA body. We can translate those different things that have been measured in a clinical trial into specific, meaningful impacts that patients experience every day. We can highlight the positive impact that changes in any of these measures mean for our lives or for patients' lives. So we can say, for example, a 2-point improvement on this score doesn't sound like a lot, but actually for people with this condition, that means the difference between them being able to look after their child and take it to school or having to have somebody else do that, just to give you an example. And they can clearly articulate with specifics how their needs are not being met by the current treatments. And on this slide, you can see that I've bolded the word specific twice. If there's one thing I'd like you to remember from this presentation, if you're ever involved in a HTA, be really specific about what happens to patients. Be really specific about the things they can do, the things they can't do, and the impact of treatments that either make that better or worse. So really show them the details. That's what they're looking for. And so today we see patients involved in many ways in HTA. Depends on the country you're in. And in the interest of time, I won't go through this in detail. But, and this is where, I really want to sort of explain why it is that we don't always get what we want as patients from a HTA process. We have to remember the central purpose of health technology assessment is to protect the healthcare system for everyone, not for any one patient community or patient groups. And we have to keep that in mind because that's what it's there for. And what that means is that healthcare systems, what they're really buying is health outcomes, not drugs. Practically they're buying medicines, but what they're really spending the money to achieve is have better health outcomes. And that's why it is the strength of the evidence that the promised health outcomes will be realized that drives much of that decision. It also needs to be a repeatable and consistent approach so that citizens can see that the same process is applied no matter the disease area. So that it's not that loud patient voice I was talking about earlier that is unfairly changing the rules for some. So that's a really important point, because as patient groups, sometimes we're often calling on HTA bodies to make a special case. We're saying, your system doesn't work for our disease. We want a different system to consider our disease. And actually that goes against the central purpose of HTA, is to make sure that it's transparent, it's repeatable, and it's consistent. So I would say the ultimate purpose of patient involvement is to improve the quality of HTA decisions. So it's not lobbying, it's ensuring that patient evidence is considered as an important part of the decision. And it means that, we're encouraged to come with evidence that supports the needs that our patient community has and really present that evidence in there. And the way that this happens, there's a range of methods used. Depending on your country, you might have informal discussions. Then maybe there is no official process of involving patients. But if the HTA body knows you exist and they're looking at a medicine in the future in your disease area, they know that they can come to you if there's something they don't understand. And again, a bit like I said with regulators, it's really important to make them aware that you exist so that they know you're there for any kind of discussions. In many countries, what you have is an open public consultation, usually via a website, where they'll say, we're looking at this particular treatment, and anybody, a nurse, a doctor, a patient group, can often input information into that consultation. You see that used a lot in South America and some Asia Pacific region countries do these open consultations. What we see though in many HTA bodies is a formal process with a written submission from patient groups as part of the evidence they consider. So they invite patient groups to actually write in to answer specific questions. And I'll go through the questions in a moment. And then many of them do that, but also have patients come to the committee meeting as patient experts and give testimony and are there to answer questions. So it's a bit of a discussion that happens in that committee meeting. And a lot of issues come up where they'll turn to the patient representative and say, what is your views on that? But equally, we've seen a lot of examples where the patients put up their hands and say, all the things you're talking about, they're not important to us. You haven't mentioned the thing that's most important to us. And that you can change the whole way the discussion goes by what you're adding there. Okay, I'm not going to go through this slide. This is a common process, but I think we've covered that. If you have no patient involvement in your country HTA, then it's really tricky, but I think it's possible to start thinking about how do we change the landscape. There are a lot of examples from other countries. There's lots of published evidence that supports patient involvement in HTA, that shows that you get better decisions if you have patients involved. So I think you need to understand the system and who controls it, who sits on the committees, who gives input. You need to understand, so when you're not involved, who is involved basically, and how do you connect with the people who are involved? So there might, for example, be some clinicians that sit on this committee. Are you in contact with those clinicians? Can you give those clinicians all of your patient insights and your evidence and say, can you make sure this is also included in their input? But on a longer term, I think you can join across many disease areas and really campaign for formal patient input into the process. So top tips for interacting with HTA and payers. First of all, understand the questions they're asking. This is an example here that many HTA bodies use. They want to know how the condition affects day-to-day lives. They want to know how well the current medicines help patients manage the condition. They want to know if you as the patient organization, if you've been able to speak to anybody who's tried the new medicine, maybe on a clinical trial or something like that, or even spoken to somebody from another country where that medicine is already available. They want your opinion. Would this medicine be expected to improve the patient's quality of life and experience of care? And if so, how? So how do you think this medicine will improve things for patients? Some of them ask this question number 5. What is the impact that this treatment would have on family or caregivers? And the last question, don't be scared of the last question. It's an important question. Are there any disadvantages that we need to know about with this new medicine? No medicine is 100% good and 0% bad. So they just want to know what is the patient view on any negatives so that they understand that. Top tips on answering those questions. Be specific. I've mentioned that already, but I cannot emphasize that enough. Be as specific as you can. Focus on the patient perspective. Sounds obvious, but we see this doesn't happen every time. Sometimes we see a lot of patient organizations really going through the clinical data in a lot of detail, repeating information that the health technology assessment body has already got from other stakeholders. You're there to really bring the patient perspective alive. So really focus there, be specific, I've said. The third one is important. We don't want to hear it, but it is important, is that pure emotion doesn't help. And what I mean by that is you're absolutely okay to say, this is a really terrible condition. It has a lot of impact on people's mental health and mental well-being. And you can talk about the devastating impact that the symptoms have on people's lives, but you have to make it specific. If you just go in there and say, this disease is terrible and we need new treatments for this disease, well, they hear that for more or less every disease they look at. So the emotion itself doesn't help with the decision-making. It's the specific examples that bring this to life that will help link the emotion to the challenges of living with that condition. The other thing I would say is work with the system you have, not the system you would like to have. And the reason I say that is that many patient groups say, okay, in my country, they're not interested in hearing about the caregiver. It's not part of their assessment to hear about caregiver impacts. And we think they should. Okay. Outside of an assessment, you can campaign to the HTA body to change and include the impact on caregivers. But if it's not part of the process that you're in, when you're actually there being invited to comment on a health technology assessment, if they're not going to listen to that, you're wasting your time talking about things they're not going to consider. So really focus on the system you have, not what you'd like. Highlight any patient types that are particularly impacted. This is a really key question. Who will benefit most from this treatment? This is not always clinical. It's not always something like people with the most severe disease will benefit most. Sometimes it can be people who live in rural communities, far away from treatment centers and specialist centers. They might benefit from this treatment most because this new treatment means they don't have to travel so often. That's just a sort of generic example, but really think through who will benefit most. Look at submissions from other HTA bodies, not necessarily in your country. So I can recommend, they're going to be in English, but I recommend you can go to CADTH, C-A-D-T-H, CADTH. That's the Canadian Health Technology Assessment Body, or NICE in the UK. Just Google them, you'll find them. They will list what other patient groups have submitted to previous HTAs in that disease area. So you can look and see what other evidence those other patient groups have put forward. It might give you some ideas, or you might be able to ask them if you can reuse that evidence or adapt that evidence for your own needs. Last point nearly is to remember, we're nearly at the end, that even though you want access to a therapy, it's not our responsibility as patient advocates to secure access. We want new medicines. That's not an issue. But we have to understand that HTA is a multidisciplinary process, and there's many reasons why a treatment may not be recommended. And the reason I have this slide in here is to really say that sometimes it can feel like the weight of the whole community's shoulders is on, is here on your shoulders when you are in a HTA. You really want patients to have new treatment options. If that decision is a no, it can be devastating to you personally. And actually, the reason why it might be a no is often outside of your control. It's not because you said the wrong thing. There are other reasons why that might be a negative decision. And I really want us to understand that, it's not up to us as the patient advocates to fix all of those things. We simply can't. And I don't want people to feel that it's only on their words that access is granted or denied. I'm going to just stop here. I was going to do a case study, but I can see we're out of time here. So I'm going to stop presenting and see if there are any questions here.
So thank you so much, Neil, for this incredible and very informative session. I think there is so much to say about HTAs, but we would need 55 webinars like this to go in depth. So for everyone in the chat, if you have any questions, you feel free to put them, write them in the chat or in the Q&A panel. We have a few minutes, so any questions for Neil, feel free to express this. But meanwhile, I have my own question that I has been asked several times by patient organizations in Guatemala or in Bosnia, and I think it was related to the slide that was coming next. What if medicine has given a negative assessment purely based on financials, on the cost of the medicine and not on the health outcomes? What can patient organizations do something, or that's the end of the story there?
Yeah, so it's a really good question, actually, because I think there's no easy answer. There's no magic wand answer. But what we see happen is in most cases, if there's been a negative recommendation, then not long after that, that gets turned into a positive recommendation. So several things happen. The medicine developer provides new evidence. So that gets rid of some of those uncertainties that I was talking about earlier. That makes them a bit surer that actually, there's value here. They can do something increasingly called managed entry agreements. And that's where they can say to the company, we will grant access, but only for a small group of patients to start with. And you have to collect evidence in our country, in those groups of patients. And from that evidence, we will then decide whether we open up the access more widely. So there's those kinds of mechanisms. But you're absolutely right, Victor. That's what happens a lot of times is there simply isn't a budget to pay for this stuff, and they're using HTA almost to hide behind that decision. And there, what I would recommend is your real target shouldn't be HTA because they're doing the assessment. It's actually the policymakers to ensure that there's better funding for healthcare, there's better access to healthcare, because that's really the politicians are standing behind all this, saying, oh, it's not my decision, it's the HTA body, when in actual fact it is their decision. So sometimes I think it's very useful for us to complain about HTA when actually some of the times we should be thinking, oh, actually we need to go to the policymakers on this one.
Okay, thank you. So I see Guillermo have a question. So Guillermo, I think you can unmute yourself or you can write.
Víctor, gracias. No, primero que todo, pues gracias por la conferencia. Tuve la oportunidad de estar en dos talleres en Bruselas con el profesor que está dando la charla, no sé si se acuerda de mí, Guillermo Gutiérrez de Fundarso Colombia. Y yo tengo una pregunta. Hoy por hoy se están hablando a nivel mundial sobre los techos máximos, los presupuestos máximos. ¿Qué concepto tiene usted con respecto a esto, con la nueva política pública en salud que se está manejando a nivel mundial?
I'm not sure I understand the question. The maximum, do you mean the maximum threshold at which they're prepared to pay for something? Is that what you mean?
Sí, cómo no. Se hablan techos máximos, umbrales máximos.
Okay. This is a particular issue with a kind of HTA called cost effectiveness HTA. And those thresholds change from country to country. And again, they're very much set by the policymakers who decide, so this idea of having a global threshold, I'm not sure that I can see that becoming a reality anytime soon, because healthcare budgets are a national issue. Based on national taxation or national insurance that you have. What we are seeing change is, especially in some of the rarer conditions, is we're seeing health technology assessment bodies being prepared to raise those thresholds, especially when it's a rare condition, or it's a particularly sort of a condition where there's no other treatments available. Those kinds of reasons, we've seen them willing to raise those thresholds. But you're right to point this out. There is no consensus from country to country over what those thresholds should be. And I think we as patient organizations and patient advocates, one of our roles is to show the differences between different countries and to show the unfairness within those differences. And that's what a lot of us do with our international work. And we see that across the globe, that there are countries that simply still do not have access to some of the basic medicines that we've seen available in many other countries for a long time. I don't know if that answered your question there, I'm sorry.
No, muy bien, gracias.
Okay, thank you.
Okay, thank you, Guillermo. So if someone else has any question, any last questions, please raise your hand now. I understand many questions, probably you will need some time to process all this information. So if you have any other questions that we want us to reply by email or by WhatsApp, you just feel free to contact us anytime. And I think Neil will be very kind to answer those questions for you in the future. So I see we are 5 minutes over the time. So first, thank you very much, Neil, for your time and for your participation in GAAPP Academy. And thank you everyone who has come to this last session of 2023. I hope all of you and many more would join us in next year for our next 6 sessions. So thank you, everyone.
And thank you for inviting me. And yes, if there's any other questions, send them to Victor. And if I can, I will answer them.
Okay, so thank you, everyone. Have a nice morning, evening, afternoon, whatever it is in your time.
Bye-bye.
Bye.